So I'm going to talk about a lot about shoulder arthroplasty tonight, and really three different types of shoulder arthroplasty: hemiarthroplasty, anatomic total shoulder, and reverse total shoulder. We'll try to cover who needs it, what the outcomes are like, what's involved in the surgery, what's the recovery like, any complications that are possible, and then really a lot of what the future holds for shoulder arthroplasty. This is a really expanding topic. The science and technology that's driving it is really impressive, and we have some really interesting things to expect in the next couple of years. So, we're talking about anatomy a little bit. Shoulder is a ball and socket joint, and actually less like a ball and socket, and it's a very unconstrained joint. So it's more like analogous to a golf ball sitting on top of a golf tee. It's not a very deep cup. Those two structures, the is the humerus, and the top of the humerus, or the ball, is called the head of the humerus, and the cup is the glenoid, which is part of the shoulder blade. Those two structures are lined with articular cartilage, which is a very smooth substance that allows these two bony structures to glide on each other, and gives the shoulder its range of motion. Because it's not a very constrained joint, it's not a very deep cup, the shoulder has a tremendous amount of range of motion. It actually has more range of motion than any other joint in the body, which allows you to have do all the things that we can do with our upper extremity. So, what is arthritis? So arthritis is the destruction of this articular cartilage, and it moves along in kind of a stepwise process. The cartilage begins softening initially, and then you develop fissures in the cartilage, and then fraying of the cartilage, and then eventual destruction of the articular cartilage and exposure of the subchondral bone underneath. Physiologically, as you go through this process, there's a lot of inflammation that happens in the joint, which we usually feel as pain, but it also leads to changes within the bony anatomy. You get hardening of the bone, you get tightening, contracture of the capsule that surrounds the joint, and this actually promotes and accelerates the process, so it becomes kind of a positive feedback loop to lead to loss of cartilage. So what are some risk factors? And we'll talk about this more as time goes on, but risk factors include history of heavy lifting, previous fractures, previous dislocations of the shoulder, infections, or prior surgery. So when we're going to talk about arthritis in the shoulder, we're really going to talk about two different kinds of arthritis. We're going to talk about glenohumeral osteoarthritis and rotator cuff arthropathy. So if you look at the normal shoulder that I have here on the left side of the screen, you can see that the normal joint is pretty well preserved. The humeral head is a ball. It's sitting on top of the glenoid. This is a good looking joint. You also notice that the humeral head is a sufficient distance underneath the acromion, which is the part of the shoulder blade there, indicated by the blue arrow. Now, when we talk about glenohumeral osteoarthritis, you see the flattening of the humeral head, the pretty characteristic osteophytes that are forming inferiorly. We actually call those goat spear osteophytes, and they're very indicative of osteoarthritis of the humerus. But that rotator cuff interval, that interval between the humerus and the acromion, is very well preserved. So this is pretty significant glenohumeral osteoarthritis, as opposed to the picture on the far right, which is rotator cuff arthropathy, where there are still arthritic changes, but this is in the setting of a chronically deficient rotator cuff, or a chronic rotator cuff tear. This humeral head has begun to migrate upwards into the acromion, eroding that acromial interval space and leading to arthritic changes. And we treat these two kinds of arthritis differently. So what are some non-operative treatments for arthritis of the shoulder? Well, we start much like we do for any other joint with arthritis, with non-operative managers to include anti-inflammatories, non-steroidal anti-inflammatories. Physical therapy can help with range of motion. particularly with rotator cuff arthropathy. Balancing the remainder of the rotator cuff can lead to a tremendous functional improvement. Steroid injections, viscosupplementation or the gel injections, which has had a lot of good success in particularly knee osteoarthritis, is currently not FDA approved for the shoulder. There hasn't been a lot of positive data showing that has a really good result. So it's not really approved yet. It's an off-label use. It's a conversation between the surgeon and the patient whether it makes sense to do this. Platelet-rich plasma, which has also been getting a lot of buzz with multiple different applications in musculoskeletal medicine, hasn't really there hasn't been a really good peer-reviewed data supporting the use of platelet-rich plasma in shoulder arthritis, and as a result, yeah, most insurances will not pay for it to be used, and it would be expensive and cash-based. Again, for a patient that's very opposed to having a shoulder replacement, these might be some things that we could talk about, but it's not generally recommended. So, kind of the history of shoulder arthroplasty. So, hemiarthroplasty or partial shoulder replacement was kind of pioneered by Dr. Charles Neer. Dr. Charles Neer is the father of modern American shoulder surgery. We owe a great debt to him and everything that he figured out over the years. He developed hemiarthroplasty originally for fractures in the 1950s, but later adapted for arthritis. Hemiarthroplasty means you're only replacing one side of the joint. So in this case, it's the humeral side. His initial implants were monoblock, one size fits all. They were cemented in place. You kind of didn't really account for patient anatomy. It just kind of got what you got, but that's what we're doing. He had really good success initially. It does not account for any glenoid arthritis or deformity. So what does hemiarthroplasty look like today? I think that it's a kind of a limited indication, especially in my practice. I think for fractures in young patients who are not amenable to plate and screw fixation for whatever reason, or avascular necrosis. Avascular necrosis is a problem that happens in the shoulder, mostly in the humerus, where there's a disruption of blood supply to the humeral head, and it leads to cartilage damage and bony erosion on the humeral head. In both these scenarios, the glenoid is actually pretty well preserved, and so in this case, it may make sense to just replace one side of the joint. Also, there is an indication for hemis in catastrophic failed reverse shoulder arthroplasty, and we'll touch on that a little bit later. It does, when we compare hemi to total shoulder arthroplasty, there's a higher revision rate and worse function, which is why I think for the most part, hemiarthroplasty has a very limited indication, and I would tend to go for a total shoulder, anatomic total shoulder in most patients. What's kind of the future of hemiarthroplasty? I think like I said, I think it's going to continue to maintain a small but viable portion of the market and for specific indications. I think in the right indications, such as like AVN in a young patient or avascular necrosis in a young patient, I think it's a great surgery. We're seeing some improvements in bearing surfaces. So pyrocarbon is one of the things that's been talked about lately and is actually on the market now. It has been demonstrated to have 300% less wear against bone when compared to metal, any of the metals that are currently in use. And so this would be attractive, especially if you're only resurfacing one side of the joint, because then that side of the humerus is going to articulate on native glenoid and not eroded as fast as we've seen previously. And as I said, it will always remain an option for failed reverse total shoulders. So anatomic total shoulder replacement. So who is the ideal candidate for this? So patients are in their 50s or 60s. They have glenohumeral osteoarthritis without significant glenoid deformity, intact rotator cuff. You have to have an intact rotator cuff to have a well-functioning anatomic total shoulder. Good bone quality. Ideally, these patients have had some conservative management, injections, physical therapy, anti-inflammatories, and they're no longer having benefit from those anymore. Then total shoulder makes sense for them. What are some risk factors? History of heavy lifting, contralateral disease. Unfortunately, shoulder arthritis is one of those diseases that if you have it in one shoulder, you might have it in the other one. In fact, it's very likely you do. history of steroid use, and history of shoulder instability. So patients that have had a shoulder dislocation at some point in their life, or they felt shoulder instability, they tend to lose cartilage, and cartilage loss at an early age can lead to arthritis at a later age. So what's involved in this surgery? So it's a same day procedure for me. You come in the morning, you go home the same day. Patients are positioned in this beach chair position that you can see right here, where you're kind of laid in a semi-sitting position. And then the approach, it's an open surgery. It's done through what's called a deltopectoral interval. So this is a natural space in your shoulder in between your deltoid, which is the prime mover of your shoulder. Everyone kind of knows what your deltoid is, and then your pectoralis major. And there's actually a very identifiable landmark called your cephalic vein that runs in between those two structures. We utilize that interval, which allows us to not really have to take down any muscle in order to get down to the shoulder joint itself. So during the surgery, we remove the top of the humeral head and we place a stem into the humerus that allows for bone to grow into that stem. The glenoid is flattened out to correct for any deformity and remove any remaining cartilage. We call this process reaming. And then the glenoid is resurfaced with a highly cross-linked polyethylene, which is cemented into the bone. So that center picture there kind of gives you an idea of what reaming is. It basically just kind of flattens out accounts for any deformity. That's what the implant looks like on the left-hand side, and then that's kind of what it looks like in the shoulder. So what's recovery? Well, because anatomic total shoulder requires the use of a functioning rotator cuff, and we do have to take down one of the rotator cuff tendons to expose the humeral head, which is called, the tendon's called your subscapularis. We do have to slow your recovery from this while we're waiting for that tendon to heal down. So typically you'll be in sling for about 6 weeks. I'll start physical therapy at 2 weeks. It takes about 3 to 4 months to really get your range of motion back. Patients, when can you get back to work? Well, if you're doing computer work, you can kind of get out of your sling at about 4 weeks and begin typing on a computer using a mouse, things like that. About 4 months getting back to golf, and about 5 months getting back to tennis. Outcomes. So patients do really well with anatomic total shoulder. So patients that only had about 95 degrees of forward flexion, so that's about the level of your shoulder, they were able to get 160 degrees after surgery, which is about that high. So 93% of the patients were able to return to golf. Revision rate is about 5.6%, which is higher than reverse total shoulder. Most common reasons we see for need for revision and anatomic total shoulder are failure of the rotator cuff, and then loosening of that glenoid component. And how have we kind of trying to manage some of those things? Well, these are kind of what the future of anatomic total shoulder. What we're seeing is stemless implants. So rather than having the stem that's placed down the humeral shaft, we're removing the top of the humerus and placing these implants. These are very bone preserving implants, which is why they are attractive. They also kind of replicate the patient's anatomy better than a stemmed implant, and have been showing really good success rate. This has become my go-to for anatomic total shoulder as a stemless implant. We're also looking at the fixation of the glenoid. Traditionally, it was a pegged implant that was cemented into place. We're now looking into biologic fixation, either through metal-backed glenoids that are porous metal that allows bone to grow into them, or through a bone implanted on the plastic implant that allows for bony ingrowth as well. The thought is that will have more longevity than a cemented implant. Augmented glenoids. So this is the way we're accounting for glenoid deformity that patients have. Is we have glenoids that have augment built into them to account for that deformity. And all of these products are available currently. So the future is kind of now for anatomic total shoulder. If we're talking about the advancements in anatomic total shoulder, I want to talk about humeral resurfacing a little bit. This is a very bone preserving procedure. So instead of cutting off the top of the humerus that we do with an anatomic total shoulder, we actually kind of mill the top of the humerus and we replace it with a cap. Um, the glenoid is actually a small plug that's placed at the area of maximal wear on the glenoid. It is completely inset within the bone, which makes it incredibly stable and very unlikely to loosen. Um, Potential advantages of a humeral resurfacing is that it kind of maintains the anatomical shape of the humerus even better than an anatomic total shoulder, maintaining the ovoid shape of the humerus and may have better kinematics. For me, this surgery is indicated for a very young patient with osteoarthritis, and it's particularly one who anticipates heavy lifting. What I mean by that is people who like to lift weights recreationally. We do know that lifting heavy can lead to glenoid loosening, and this is someone I may want to consider doing a humeral resurfacing in. So, talk about reverse total shoulder. So, reverse total shoulder was designed to address arthritic shoulder in with deficient rotator cuff. So in the early, 50s, 60s, 70s, even in the 80s, we not have a great answer for those patients. Trying to repair the rotator cuff at the time of shoulder replacement was met with very poor results. There were several designs trying to figure out something similar to what we have today as the reverse, but they didn't work very well. So Dr. Paul Gramont in France in the early 90s figured out how to, by medializing the center of rotation and placing a ball on the glenoid, creating a very constrained joint, you could allow the deltoid to elevate the shoulder in the absence of a rotator cuff. So reverse total shoulder was first FDA approved in the US and the United States in 2003 with the DePuy Delta Extend. In the last 20 years, we've seen significant amounts of technological improvements with this, including improved glenoid fixation, increased lateralization of the implants, which has been shown to improve range of motion, changes in neck angulation, which again, better probably replicates the native anatomy and has improved range of motion. And as a result of this, we've seen increased use of reverse total shoulder. So you see the graph here on the right showing from 2012 to 2017, the amount of reverse total shoulders placed in the United States has gone up. And if we took that out to 2023, we'd see that blue line continue to increase up and maybe even anatomic kind of drop off a little bit because reverse total shoulder is such a predictable surgery that does very well. This led us to expand our indications for it. Reverse total shoulder is being used for a lot of proximal humerus fractures, particularly in elderly patients, osteoarthritis with an intact rotator cuff, and a patient who's a little bit older and doesn't want a chance of ever have to have another shoulder surgery. And then also massive non-repairable rotator cuff tears where we don't have a great answer for repairing that tissue. A reverse can restore range of motion very adequately. So who's the ideal candidate? For me, ideal candidate is a patient over the age of 70, patient with either a massive rotator cuff, which I don't think is repairable, or they have some shoulder arthritis or a combination of two. We call this rotator cuff arthropathy. We talked about that before. Ideally, a patient has range of motion deficits. If they have really, really great range of motion, I tend to kind of favor conservative management for that. They've failed injections and physical therapy. Risk factors. So previous rotator cuff repair. Unfortunately, especially if you have a rotator cuff repair at a young age, you're probably at a high risk to develop rotator cuff arthropathy. Patients have multiple steroid injections, untreated rotator cuff tears. So we see this sometimes where a patient was told they had a rotator cuff tear. They didn't get surgery. Many years have passed, and now they've progressed on to have some arthritic change associated with that. And then overhead professions. These patients tend to be at high risk for rotator cuff tears and then subsequently rotator cuff arthropathy. So surgery is again done through the deltopectoral interval, very similar to an anatomic total shoulder. It's the same approach. Given that patients getting the surgery are typically a little bit older and sometimes have some medical problems, I do tend to keep those patients one night in the hospital and send you home the next day. However, in certain situations, if you're very healthy and motivated, I'll send you home the same day. We again remove the top of the humerus and place a stem. We ream the glenoid like we did on anatomic, but this time we place a metal base plate onto the glenoid. And this is designed to have some sort of porous metal on the back side of it that allows for bony ingrowth. And this is screwed into the glenoid with multiple screws. Then a dome is placed on the base plate. We call that a glenosphere. And then the stem and the humerus gets a cup placed on top of it. So what does all that look like? Comparing that to a total shoulder, which is pretty easy to understand. It's just replacing what you have in a normal shoulder. This is what a reverse total shoulder looks like. You can see the glenosphere or glenoid sphere in this diagram here, the humeral cap and the stem. And so what this does is it medializes the center rotation of the glenohumeral joint and creates a fulcrum that allows the deltoid to elevate the shoulder in the absence of a functioning rotator cuff. The surgery takes about 1.5 hours to do, sometimes a little faster, sometimes slower, depending on patient's anatomy. Recovery, this is a fairly quick recovery, only about 2 weeks in the sling because it is not dependent upon the rotator cuff to function. So we don't have to slow your rehab as much as we do with an anatomic total shoulder. I usually start physical therapy about 2 weeks working on range of motion, 3 to 4 months working on getting range of motion, although patients will make improvements out to a year from surgery. About 4 weeks, patients get back to computer work, 3 months working on getting back to golf, and 4 months back to tennis. Outcomes from this, range of motion tends to be a little bit less after a reverse total shoulder, whereas we're talking about 160 degrees of forward flexion is expected with an anatomic, probably closer somewhere between 100 and 130 degrees of forward flexion is what you would expect from a reverse. This patient on the right here is 6 months out, and obviously he has an excellent result. So people can get very good range of motion from a reverse. It's just not as predictable as an anatomic. So what are the complications associated with a reverse? So loosening, so this is loosening of any component, particularly the glenoid side, is about 1.5%. Acromial fracture is about 4%. Infection, 3%. Dislocation, 1.2%. If that sounds pretty daunting, just for comparison, those numbers in red are the same complication risks you would find with total hip arthroplasty, which is probably arguably one of the most successful surgeries we have today. And you'll see those level of complications with this. So overall, I think reverse shoulder is a very reasonable surgery with excellent outcomes. In a recent study, 94% of reverse total shoulders placed in were still functioning well at 10 years. And recognize that those studies are based on implants that were placed over 10 years ago. The technology is significantly improved, and so I would expect that number to be even better if that study was repeated today. Common reasons for revision, base plate loosening, instability, persistent instability, and or fracture. So what's the future hold for reverse total shoulder? Well, this is all very exciting. The technology growth with reverse total shoulder has been explosive in the last several years. I think in addition to seeing new technology come out, we're going to see a convergence of technology as well, which is to say that if you look at all the different manufacturers of shoulder implants today, you'll see a wide variety in the style of those implants. You can see two different base plates here. One is a screw-in base plate. One has a post. They have different configurations. They have different amount of screws that can be placed into them. And I think over the next couple of years, we'll start to see these kind of migrate into a kind of a standard or less variability between the base plates as we start to figure out what really, really works. The reason probably we haven't seen that yet is they all work really well so far. I think we'll also see some of this convergence on the humeral side as well. Currently, there's two different styles of humeral stems. There's an inlay stem where the cup actually kind of sits within the bone versus inlay where the stem sits in the bone and then the cup sits on top of the bone. I think we'll probably see a migration more towards inlay. That certainly seems to be what I'm seeing come out from most manufacturers is they're migrating towards inlay, as that tends to be more bone preserving, less what's called stress shielding, which leads to reabsorption of the greater tuberosity and better range of motion. My preference is certainly to use inlay, so I think that we're heading that way. The other advancements I think we'll see on the humeral stem is initially Gramont's stem was a 155 kind of non-anatomic angle cut on the humerus. We've seen a transition to the Frankel style stem, which is a 135 angle on the neck. This has been associated with lateralization of the implant and led to better range of motion. Um, it, without any deficits in stability. Further advancements, so computer 3D modeling and planning of these surgeries. So currently we can obtain a high resolution CT scan. We can load that into a computer. We can plan our implant. We can see how much backside contact we're going to get on those base plates based on the deformity of the glenoid. We're able to template out the size of the components we have. Even some of these um, computer modeling systems actually allow you to even predict the range of motion you'll get with the given implants. So this allows the surgeon a lot more predictability in terms of what he's going to do in the operating room. As we kind of are able to do this 3D modeling, we're starting to be more and more aware of glenoid deformity prior to surgery, and this has led to an advancement in base plates, just like we're doing in anatomic total shoulder, that can account for that glenoid deformity. So these are augmented base plates that can be placed, and this is actually beneficial, and we have to ream a lot less bone in order to correct that deformity. The 3D modeling has actually allowed us to look at really significant cases of glenoid deformity, where we actually can do a custom-made 3D printed metal glenoid that can be specifically designed for the patient with significant amount of glenoid deformity. Takes about 6 weeks to make and can be placed into a patient. This allows us to take care of a significant amount of glenoid deformity that we may not have been able to take care of in the past. These tend to be revision scenarios, and so this has really expanded our ability to revise reverse shoulders that have problems or fail. Revision options are continuing to improve for the humeral side as well. So as you have to revise the humerus, we worry about bone loss, both in length, but also in the greater tuberosity, or the bump that you see there on the humerus. And we've determined that that has an effect on the function of the shoulder. The deltoid wrap, as we call it, over that bone, and tends to be very important. So we actually have implants that replicate that now. As we get increasing bone loss in the humerus, we have options that are ways to replace that bone. These are modular implants and allow the surgeon and the OR to build up his implant to whatever he needs it to fit and account for that significant bone loss. So further advancement of the computer modeling is the way to translate that plan into the OR. And there's multiple different systems on the market currently on how to do that. Some use this reusable metal targeting device, which has these metal feet that you see on the left side, and they're specifically calibrated based on the computer model to account for the glenoid, to help us fire the central drill pin, which helps us when we place your glenoid base plate. There's plastic 3D models, that 3D printed guides that accomplish the same thing. And then there's even complete navigation using sensors that are placed on the patient, allow the screws to be navigated actually during the surgery. So what's the future? Real future hold is augmented reality. So this is, believe it or not, this is actually currently happening in limited markets. This allows the surgeon to take their 3D, their computer model, and actually have it visual to them in the operating room. They can actually overlay it over the patient's anatomy as they're doing the surgery to help mark out, this is where I'm going to put my pin, this is where I'm going to do my humeral cut. All of it's based on these preoperative templates that are available to the surgeon. What's kind of the future of augmented reality? There's the sky's kind of the limit on this. Things that have been discussed is virtual surgery. The patient, if you have a very complicated case, the surgeon can put on these goggles, he can go through your entire procedure before he even sets foot in the operating room, anticipating areas that are going to be a challenge for him and help figure out solutions before he even lays hands on the patient. Um, this can also lead to what's been talked about is, especially in a case where a very challenging case, a world expert in shoulder arthroplasty from France or Boston or wherever could log into the virtual reality, see what the surgeon is seeing in the OR, and assist in the surgery and provide advice throughout the surgery. So this is really exciting. We'll see that what the future holds for this with augmented reality and shoulder replacement. Robotics. So in terms of robotic assisted surgery, this has become very common for knee and hip arthroplasty, and many surgeons across the country, this is their standard. It has not come about for shoulder replacement yet, but it is coming, and probably in the next year or so. Unclear as to what that will look like. We know that in knee and hip arthroplasty, it decreases the need for cutting jigs and things like that, makes it a more reproducible surgery. In shoulder arthroplasty, potentially could lead to different surgical approaches and less extensive approaches, more minimally invasive. But time will tell what robotics has in store for shoulder arthroplasty and how it will change shoulder arthroplasty for the future. So just kind of my closing thoughts on this. I think shoulder arthroplasty, whether anatomic or reverse, can dramatically improve your quality of life, improve your range of motion, allow you to get back to activities that you haven't been able to do for many years. The technology is rapidly evolving, continues to evolve. As someone who does shoulder arthroplasty on a regular basis, I'm very excited by all the technology that's coming down the line and how it will help me take better care of you, the patients. I think shoulder replacements today are better than the ones that were put in even 5 years ago. Better range of motion, less complications, and we're definitely trending toward more bone preserving procedures with the idea that if you need a revision in the future, there's good options for you. Most of these procedures can be done as an outpatient or a short hospital stay. And then I think we're going to continue to see improvements on the technology, both in areas of 3D printing, patient personalized implants, virtual reality, even robotics will allow us to tackle more complex cases that we didn't have a good answer for before we have an answer for now. And so with that, I'm happy to take some questions, and thank you for everyone for your attention. So I'm Dr. Patrick Jones with Southeast Orthopedics. There's a question about who I am.
Can someone over 70 get an anatomic total shoulder?
Yeah, so when I say that I kind of over the age of 70, I usually do a reverse. That's a little bit of a guideline. Typically, a patient who's very active, very motivated over the age of 70, who has a intact rotator cuff, can definitely get an anatomic total shoulder. There's a slightly higher increased rate of revision. I tend to find that patients over the age of 70 are kind of, doc, I just want one surgery and to be done. I don't want any chance of revision. And I think a reverse is more predictable, but certainly it's a conversation I would be willing to do an anatomic in someone over the age of 70 if they met the right criteria.
How bad does my shoulder pain have to get before considering joint replacement?
Yeah, so that's a good question. So patients I hear frequently in clinic that they don't want surgery. They don't want a shoulder replacement. It's a big surgery. I don't want to go through with all of that. And I appreciate that and understand that. I think if you have had all the conservative management that we talked about, so steroid injections, physical therapy, you're not able to do the things you want to do and you're living in pain, I think that it's a very reasonable surgery that's available to you. And I think that with most joint replacements, knee, hip, and shoulder, I think the majority of patients say afterwards that they wish they had done it sooner. So I think that if you're living with daily pain and those conservative managements aren't helping you anymore, it's definitely time to talk about replacing your shoulder.
How do untreated bone spurs influence surgery types?
So I think when we're talking about bone spurs, there's kind of two different categories that we're talking about. One is osteophytes, and so the treatment for them is the shoulder replacement. They are really just in general denote that you have arthritis. The other bone spur that gets talked a lot about is off of the acromion. And so we talk about spurring of the acromion. The acromion sometimes hangs down a little bit, and that can abrade on the rotator cuff. So if you have a bone spur in the absence of a rotator cuff tear, that's probably okay. But if you have a rotator cuff tear and that's caused by the bone spur or the acromial spurring, that can lead to problems with rotator cuff arthropathy, non-functioning rotator cuff. You would probably need a reverse as opposed to an anatomic total shoulder.
Is there a weight limit for lifting your shoulder after surgery?
No, after you recover, for an anatomic, it's kind of like recovering from a rotator cuff. So I do have some lifting restrictions for the first, 2 to 3 months, but then you can get back to it for sure. And for a reverse, really not. I could let you get back to lifting as far as like lifting and activities of daily living. Now, with patients that like to lift weights as a recreational activity, I would suggest not lifting heavy, lifting, kind of low weight, high rep for fitness. That's certainly reasonable. But I don't have any hard and fast lifting restrictions in terms of a weight that you can't lift anymore.
When should I expect to feel relief from my shoulder pain after shoulder replacement?
So most patients that I've done this procedure on have significant amount of pain relief even right after surgery. Even the next day in the hospital when we're seeing them, they have feeling they felt they've had a big surgery, they're sore, but they feel better than they did before surgery. They have some pain relief almost immediately. Now, there will be some soreness and pain as you go through physical therapy and recovery from this, but it should get a little bit better, every week or so. So I would say that you should have some pain relief right away, and then progressively improvements, out to 3 months or so.
Are there activities I cannot do after shoulder replacement surgery?
Um, No, not really. I really am a big proponent of getting back to the things that you enjoy doing. So, you know, as far as recreational activities go, really don't have a whole lot of restrictions. There are things that you can do to, be nice to your shoulder. And like I mentioned, heavy recreational weightlifting is probably not advised, and that's really because we've seen, especially with the anatomic total shoulder, that can cause loosening of that glenoid component over time, and that would lead to needs for revision. So I try to discourage people from heavy recreational weightlifting, bench press, overhead military press, things like that. But in terms of recreational, golf, fishing, tennis, swimming, all paddleboarding, all of that is acceptable after a shoulder replacement.
Will pain go away long term, say like 1 year after surgery?
So, yeah, I think patients will continue to have improvements, over time. So, initially, I think there's going to be some improvement in pain right away, and then I think patients will make improvements in range of motion, function, and pain out to a year from surgery, and maybe even further than that. Um, Obviously, there are patients out there with well-functioning shoulder replacements for years. Sometimes a poorly shoulder that's been continually painful is certainly worthwhile to get looked at. Just like replacements of any other joint, sometimes we can get loosening. Or there's a reason that the shoulder is painful, not functioning very well. And that's certainly worth looking into. But yes, patients will continue to make improvements out to a year.
Will it help with numbness in your hand?
Um, Probably not. A lot of times, shoulder pain or pain with pain that radiates down the arm into the hand uh, usually has a cervical spine origin of the pain more so than the shoulder. And I certainly see plenty of those patients on a daily basis. And evaluate the shoulder, find the shoulder is not the source of pain. It's really coming from the neck. And I have excellent colleagues who are experts in taking care of that kind of neck pain that I'm happy to get them involved with.
I had a reverse shoulder replacement 3 years ago and now need the other shoulder replaced, also reverse. Will different parts be used?
So it kind of, I think most surgeons have a brand that they are comfortable using. Um, I think that there's been no data that suggested that one company's parts, for lack of a better term, are better than any others or function any different than any others. So I think in general that the surgeon will use the company and brand that he's most comfortable using.
I have fairly good range of motion but have constant pain. Is shoulder replacement a viable option for me?
Well, I think that's kind of a complicated question because why do you have so much pain in your shoulder deserves an evaluation. Is it caused by arthritis? Is it caused by a rotator cuff problem? Is it caused by a labor problem? I think that question would require some more information, imaging, and an exam to make that determination. All right. Well, I want to thank you all for attending and listen to me talk about one of my favorite topics. And thanks. Have a great night.